I thank our panel of faculty speakers today, and I'd love to introduce our next speaker session. We are going to be talking about reoperative surgery, the when and what, and we have Dr. Tom Watson, who's a professor of surgery at Georgetown University School of Medicine, Dr. Brian Louie, the co-director of the thoracic surgery program at Swedish Cancer Institute, and Dr. Adrian Park, a professor of surgery and the chair of surgery at the Anne Arundel Medical Center in Maryland. They are going to be talking about reoperative surgery, and we will go on to a live Q&A after.
Watson from Washington, D.C. This session is on the redo fundoplication. Not that any of you have had failures yourselves, but when you get sent that fundoplication that's failed for whatever reason and the patient's having symptoms, what do you do? And of course, these are very difficult operations at times from a technical standpoint, from a decision-making standpoint, and they certainly require some judgment and experience and expertise to handle them the appropriate way. We're fortunate today to have two of our esteemed colleagues, Dr. Adrian Park from Anne Arundel Medical Center in Annapolis, Maryland, and Dr. Brian Louie from Swedish Medical Center in Seattle, Washington. Guys, welcome. Thanks for joining us.
Thanks for the invite, Tom.
So, Adrian, I thought I'd start with you. In your practice, what's been the most common mode of failure that you've seen, and why do you think that's the most common mode?
Well, I think there's a couple of things. I'd say, first of all, that there's elements of technical failure. I think that I see a lot of cases that are done where instead of a fundoplication, the patient's had some kind of modified torsion of their stomach done. In broad strokes, so I'd say technical, and then the other category, and there are various ways that the technical failures can manifest, but the other thing is what I'd call patient engagement, something I'm spending a lot more time on now, and patients who have, even if they've had a good and sound fundoplication and hiatal hernia repair, and they go on and live life as though nothing has to change, gain a lot of weight, and kind of abuse that reconstruction. Those are probably, in terms of broad categories, the ones that I'd see the most.
Brian, what's been your experience?
Well, you know, I think my experience is not vastly different than Adrian's. I think there are folks who have worn them out, and you see the stretching and the distortion of the fundoplication they had previously. Out here, hiatal failure, I think, is still the one biggest issue with migration and through the hiatus, and I don't think that we've entirely solved that as a group of foregut surgeons. And then I think Adrian's correct. I think there's a good chunk of patients who show up with dysphagic type symptoms, and there's a torsion to the wrap. It's not built symmetrically, and I think whether they're pulling the wrong section of stomach around in the fundoplication, they get a torsion to it, and something happens to it, and then they're complaining of dysphagic symptoms.
So in those cases, particularly when you're having dysphagia, the thought process always has been to completely undo and redo the fundoplication. Are there ever times where you guys will just leave the fundoplication intact, particularly if it's a recurrent sliding hernia, just pull that fundoplication back down, leave it intact, and do a cruroplasty? Or do you always try to redo the fundoplication, even if you've done it yourself the first time? Brian?
For me, I used to think maybe there was the occasional chance that you might just pull it down and redo the cruroplasty, but for the last multiple years, I've taken everything down, straightened it all out, and started from the beginning, because something's led to the failure, and I think you should start from as close to standard anatomy as you can to rebuild that fundoplication.
How about you, Adrian?
Yeah, I agree. They've come to you. It's a complex operation to undertake, and in many ways, I think it's their best and sometimes last shot. And I will always take everything down and reconstruct afresh. I know that John Lipham's he's an exponent of the just the crural repair, and his group just wrote a paper on simply doing the crural repair. These patients, when you see them as recurrence, the viscoelastic properties of the crura are very different in the redo situation than in the native crura when they've never been operated, kind of the fibrotic changes. And so I'm a little reticent to just think that a cruroplasty is going to suffice in a situation like this.
Okay, thanks. Now, I assume if the first operation had been done minimally invasively and you're asked to redo it, I would assume both of you guys would probably start minimally invasively on a redo. Am I correct on that one?
Correct.
Are there ever times, particularly after, say, a couple failures, or maybe there's some mesh at the hiatus, that either of you would start with an open approach or through the chest? Brian, since you're a thoracic surgeon.
I think in my practice, I've almost always started the redos minimally invasively. I counsel the patients that there's a small chance that we will be open, but with increasing experience and with our ability to do things laparoscopically, I haven't found the need to open anybody's belly. Now, having said that, over the last year or so, I've come across a couple of patients where the bellies were hostile, had multiple laparotomies after, either we'd been in there years before or somebody else had done a fundo. And I still reserve the option as a thoracic surgeon to do it through the chest. And we've had some good outcomes with the redos in the chest. And it's made me wonder and give pause for that third time redo or that second redo where, we're trying to understand length and we're trying to understand better crural closure, whether Dr. Pearson's original series is still the best option. And so lately we've done a few more chest operations than we have in the most recent past with good outcomes. And I still think there's a place for transthoracic repair.
Yeah, I've occasionally seen some patients with big recurrent paraesophageal hernias, particularly on obese patients. And I just think it's going to be really very challenging to do them laparoscopically. And I have gone through the chest on rare occasion. Adrian, what's been your experience?
Yeah, it's got to the point, having done this for many, many years, that I know, and I tell the patients that if I can't do it laparoscopically, I can't do it through the abdomen. Making an incision is not going to change anything for me. We know our data really well. We track it very closely, as I know you guys do yours. And I know that I can tell our patients that in redos, north of 99%, we're able to complete laparoscopically. And it's actually just under 1% of these that no matter what I do, I simply cannot get enough length or whatever it is. And on those occasions, I'll do all the mobilization and have my thoracic colleagues come in, and it's a pretty easy approach from above once we've done that. But that's less than 1% of our cases now.
Yeah, fair enough. And even with that low percentage, I assume you have a conversation with the patient
Absolutely.
then about the possibility of conversion. And it sounds like you have a thoracic surgeon on standby for those cases where that might be even on that rare case.
That's a great point to raise because patients are, as we know, are so very different. And so I always tell patients, particularly in reoperative, the revisional surgery, that if at any point, obviously, I feel it's more unsafe to proceed than retreat, we're retreating. But I also gauge it with the patient because some patients would rather wake up and discuss their options rather than going to sleep, expecting a few small incisions on their abdomen and then waking up perhaps with a thoracotomy. So I really gauge it per patient. Some of them say, do whatever you have to do. I don't want to wake up, just do it. And others say, we'll talk about it between, and then we just do it the same admission.
Okay. Brian, has that been your approach?
No, I think much like Adrian, if we say we're going to start in the belly, we'll finish in the belly. But if I make a decision to do a chest approach, generally I've made that decision up front based on many factors, degree of esophagitis, the presence of a stricture, what the recurrence looks like. I've made that decision up front to go into the chest and have that conversation. And so I tend not to. The conversation I have from the belly operation is if we weren't going to be in the chest and we're all laparoscopic through the belly, the question is if we can't get enough length, are we going to do a near esophageal jejunostomy, Roux-Y, as our bailout option? And so that conversation is had up front, and we plan for that possibility up front.
Do either of you guys have a number in your head about the number of prior failed fundoplications where you're just not even going to attempt another redo? Back when I was training 25 years ago, I was taught this 3 strikes and you're out rule, that if they've had 3 failures, that's pretty much it. And I must say in my own experience, sometimes I find that third operation to be awfully tough. And a lot of times I think even 2 strikes and you're out. But it obviously depends on what's been done before. Do you guys have a number in your mind? Brian, I know you've published on this.
You know, Tom, I think I have a basic idea what I think I might be doing. But I think you're right. I think, you know, the first time they have a revision, I think we can get that done laparoscopically and we can get a generally good outcome. But when we are on redo number 2, then we're starting to really think about, okay, it's the definition of insanity. Are we going to do the same thing over and over again, having it fail? And I think there are some patients in whom the hiatal closure is the real problem. And I think every foregut surgeon has seen them where somebody's done a hiatal hernia repair. They failed early with early recurrence. They've been revised. The hiatal closure has failed again. Those are the folks where I think we got to try to do something different. You know, it's different if they've had their fundo for 20 years and now they got recurrent reflux. That's a different game than I've had 3 recurrences in 18 months or 2 years, and I'm now seeing, you know, Dr. Park, Dr. Watson, or Dr. Louie for a revision after a community surgeon has tried or another surgeon in the city has tried 2 and 3 times to do the same operation. That to me is a decision to bail out and try something different.
Adrian, what are your thoughts on that?
Yeah, it's the latter patient that you know, you do this long enough and you see them and you do things as you always do them and as you refine your technique, and then you have these just utterly even post-operatively intractable refluxes or you know, just hernia formers or recurrent hernia formers. So you know, when I was young and immortal, I would be doing 3, 4 you know repairs or 3rd and 4th repairs. I'm really much closer to the 2 strikes and at most 3 strikes. So if it's been done, you know, saying elsewhere, and I think that it's you know, been a poorly constructed, then for sure we'll revise it. And you know, I've got one this morning. We did one, and it was a 3rd, and it's, you know, because it had been done by not kind of dedicated or, you know, weekly foregut surgical practice type people, and there was a fair bit. You know, the architecture of the wrap was the thing at issue. So, but so there's no set number, but it's a tougher and tougher sell after a second revision to go straight back and do another a different operation, yes, but not a revision, a further revision.
And if another fundoplication is not an option, what is your guys' alternative reconstruction of choice? Is it some sort of Roux-en-Y? And if so, there's a lot of technical elements about how you handle that proximal gastric remnant and also what you do with the distal stomach. Brian, do you want to start?
Yeah, I think if I've committed to, you know, a non-fundoplication option, then and often that's going to be a bypass. And so I think my experience and ours at Swedish has been colored by, you know, some of the bariatric challenges that they've had with herniated pouches, and they still have reflux. And so we tend to follow, or we tend to be a group that goes to near esophagogynostomy, and we do it laparoscopically with a small assist, and we use the EEA. I tend to leave the stomach there. If it sits nicely, I leave it there. If it tacks up to the wall nicely, I'll put a G tube in it and use it as a feeding tube. And then once it's removed, at least if they need an ERCP downstream, somebody can dilate up that tract if they really needed to do a lap-assisted ERCP. But sometimes the stomach just doesn't stay there, so we just leave it. We've left it unless there's some pathology in the stomach that needs it to be resected.
And if the patient demonstrated any evidence of gastroparesis prior to the surgery, might you add a pyloroplasty at that time?
Yes, possibly we would.
Adrian?
Yeah, very similar. So it would move to a small, very small pouch gastro J, and I too leave the remnant in, just because you never know if you need it for a conduit at some point, or there's no need to resect it.
Okay, unfortunately, our time is short. I think we covered a lot of ground here. Thank you guys for your insights, and it was really a great session. Have a good evening.
Thanks,
Thanks
everybody.
very much. Appreciate it.
Okay, great. Thank you to all our speakers for that excellent discussion. So our first question from the audience is actually for Dr. Louie. Do you use FLIP for revisional surgeries? And if you do you do it preoperatively or intraoperatively?
Thanks, Abe. We have just recently acquired the EndoFlip technology, or at least the new version. We had the old version for years, and we had played with it, but we have not been using it for revisional surgery at the present time. We've been having engagement conversations with Dr. Ujicki about his protocol that he's been using recently, and hopefully get back into that. We're not certain of the value, but we haven't also been using it. So hopefully we can figure that out going forward.
Great. Next question is for Dr. Watson from the audience. What is your approach to the obese patient with a hiatal recurrence? Is there a BMI cutoff where you will not operate, or you would recommend bariatric surgery?
Yeah, good question. I generally use a BMI of about 40 in most cases for automatically going to a bariatric operation, just like consistent with other bariatric procedures. And somewhere between 35 and 40, I think there's some judgment whether you redo the fundoplication or convert to a Roux-en-Y type operation. And that really depends on the patient's desires. Are they willing to undergo a bariatric operation? Are they satisfied with just a redo fundoplication? So, but above 40, I would be reluctant to put them through a redo fundoplication. I just think you're setting yourself up for failure.
Great, thank you. Next question is for Dr. Louie again. Knowing that recurrent hernia is the largest reason for failure in the Nissen patients, what are your thoughts about converting these patients to links?
I personally have not converted a Nissen fundoplication to links at the present time. I know Dr. Lipham has, and so have others. I generally haven't been as in favor of converting those. I think the amount of scar and the challenge with the hiatus in a revision fundoplication to go to links may be problematic, but I also don't have any particular experience with that, and we've stuck with standard principles for the most part.
Thank you. Dr. Katz, a question for you. Are you wearing these N95s that you find so uncomfortable, even for the COVID-19 negative patients?
Great question. Yes, I wear them for all the procedures that I do, both in the endoscopy lab and in the motility lab. I'm even wearing them in the office, seeing patients as well. All kidding aside, for me, it's just the safest way to get through the day and make it work.
Great. Thank you again to our panel of speakers today. We really enjoyed this session on foregut, the nuts and bolts of the procedures and surgeries. I'm going to hand it over to Dr. John Lipham, who's going to talk about what comes next. Thank you.
All right. Well, thanks, Tanuja. I think you got a bit of a delay.
Yeah, go ahead.
Thanks, Tanuja. I think that was a phenomenal first part of the day. Rest assured, some of the stuff we didn't get to this morning and that we didn't get to yesterday, we are going to try to get to in the second portion of this afternoon. So what that translates into is we may run a little bit over in the afternoon, but it's a Saturday night. Where else do you have to go? So what we're going to do now is we're going to break. I do want to remind you, if you look at your web screen there, down on the right-hand side, there are two links. One for a discussion on payer coverage and advocacy, as well as some non-CME events that will be occurring for the next hour and a half or 2 hours. We're going to come back promptly at 2:30 p.m. Eastern for the afternoon session, which will include something called Meet the Press, which should be pretty exciting, 60 minutes, our abstract or podium presentations from the residents and fellows. So it should be actually a tremendous afternoon. So I encourage you to come back, like I said, promptly at 2:30 p.m. I will see you then.